genetic counselor. That means that I'm specially trained to both interpret family histories, take a medical history, and then talk about what different testing options are. And then on the back end, identify and talk out with a patient what the testing results mean in the context of a personal and family history, but also help in the decision process, because as we'll talk today, genetic testing is really personalized, and so what's right for one person might not be right for another, and so there are a lot of factors to consider, and we can really help individuals and their families try to figure out what is the best decision for them and their families. So when it comes to the field of cancer genetics, I just want to take a step back and mention that most cancer is actually not hereditary. So most cancer happens by chance. In general, only about 5 to 10% of cancer is hereditary, meaning that there is an inherited change being passed from one generation to the next that increase the risk for someone to develop cancer. There are certain cancers that are considered more hereditary. So because this is a gynecologic cancer support group, I'll mention that ovarian cancer is considered more hereditary. So instead of that 5 to 10%, we quote about a 20 to 25% chance that it is hereditary. We also have that gray familial cancer category, which means that sometimes we see more cancer in a family than we'd expect. We might not be able to identify a specific genetic cause, and we think, maybe it's because of small genetic factors that are adding up that we can't account for at this point in time. Or also, families often have shared environmental factors. So, families grow up together, they might have similar eating habits, similar exercise habits, but also might have been exposed to similar pollutants. And so we can't always account for a familial cancer clustering. But I will be focusing on the smallest piece of the pie for the rest of the talk. So how does this happen? In non-hereditary cancer, that individual is born with 2 copies of their gene. So we have 2 copies of every gene. We get one from our biological mother and one from our biological father. When it comes to cancer genetics, the job of these genes, for the most part, is to protect us from cancer. So if we have 2 working copies of the gene, then we have 2 layers of defense against cancer. Over time, in this non-hereditary cancer patient, 1 copy has a mutation, which we call the first hit. So it stops working. We don't know fully why that happens. Over time, a second copy might stop working, and that's when cancer can develop in a very simplistic form. However, someone who has a hereditary risk factor for cancer, that person was born with one of their copies already not working properly. So most of the time that is inherited. So they inherited it from either their mother or their father, and that's important. This can come from mom or dad. And so that person was already 1 layer down of defense. So it's almost like they were 1 step closer to developing cancer. And it's not something that they did or they could have prevented, but it's just something that was passed down in the family. And because of the way that this happens, we see certain patterns in families or individuals with hereditary cancer. So I call these the red flags of hereditary cancer. So because this risk factor is present in every cell of the body, and these genes often work in different areas of the body, we often see that these individuals are at risk for multiple cancers. So someone who has a hereditary cancer risk might have developed more than 1 cancer in their life, or their relatives might have developed more than 1 cancer in their lifetime. They might develop cancer at a younger age because they were already born with 1 copy not working properly. Then it's almost like they're 1 step closer to developing cancer. So we do see younger ages of diagnosis. And then we also see rarer cancers. So I had mentioned ovarian cancer is considered more hereditary, and that's because it is a rarer cancer. Other types of cancers might be like male breast cancer. These are all red flags that a genetic counselor looks for when they're taking a medical history. There are also some ancestries that we see a higher incidence of mutations in. So on your forms, they might ask you if you're Ashkenazi Jewish, so Jewish, someone who's of Eastern European Jewish ancestry, and that's because there are higher incidence of specific types of mutations in these populations. So the chances of finding something would be higher. How are these passed down in families? So if someone has that mutated or not working copy of the gene and working copy of the gene, anytime that individual has a child, there's a 50-50 chance which copy they pass down, either the working copy or the not working copy. And that's why we can see in families this being passed down, but it doesn't mean if someone has a mutation that their child would definitely have the same change. But this is why it's important for family members, because especially if it's inherited, then we would say, you know, their siblings also have a 50-50 chance, and so it can impact family members as well. I just want to check for questions so far. It looks like nothing. This can then come into play for reproductive implications, which I mentioned for family members mostly. Some individuals would use this information for what we call IVF with PGTM. So that stands for in vitro fertilization, meaning they take the egg and the sperm outside of the body. PGTM stands for pre-implantation genetic testing, M for monogenic diseases, meaning that they're able to test for the specific mutation in a family. So they take the egg and the sperm outside of the body, they create embryos, and then test the embryos for which might have the mutation and which might not have the mutation, and then transfer the embryos that don't have the mutation. This is not what everybody wants to do. Some people might consider it. So I do mention that it is an option available. The other factor that's important to note is that while I mentioned that most of these are passed down in that 50-50 manner that we call autosomal dominant inheritance, some genes, like you might have heard of BRCA2, which I'm going to talk in a lot more detail in a few minutes, having one not working copy increases the risk for adult onset cancers. But if both members of the couple both carry a mutation in the same gene, so let's use BRCA2 as an example, then there would be a 1 in 4 chance, and that's that circled copy, that both parents pass down the not working copy. And that actually causes a different condition called Fanconi anemia, which is a bone marrow failure disorder. These children also have an increased risk for certain limb anomalies and childhood onset cancers. And so there are reproductive implications outside of the adult onset cancer risk if both members of the couple both are carriers of the same condition. And then most of the genes related to hereditary breast and ovarian or uterine and other gynecologic cancers are not childhood onset, but there are a few. And so sometimes people would use that in reproductive decision making if they know that it would impart a childhood onset cancer risk. Okay, again, I'll check for questions. There are many genes associated with gynecologic cancers. I just use these examples. The top and bottom are from 2 different labs that do genetic testing. And these include different genes. Some of them you might be familiar with, like BRCA1 and BRCA2 are, I think, the most famous. But there are a lot of different genes associated with gynecologic cancer. And I think that's also important that our ability to test for multiple genes have changed over time. And so sometimes someone might have had genetic testing maybe 4 or 5 years ago, but what we're able to do now is very different. And so someone might have tested negative for maybe BRCA1 and 2, but might have not been tested for some of these other genes. But as I mentioned, BRCA1 and 2 are the most famous of the ovarian cancer genes. And that is because they do account for a high proportion. So this is a very busy chart. I just wanted to give a sense, and I'm going to go piece by piece. But the first column is the type of cancer. The second is someone who has a mutation in BRCA1. The third is for someone who has a mutation in BRCA2. And the fourth column is compared to the general population. So when we think about ovarian cancer risk in the general population, the risk is about 1.5%, which is why, or around there, you might have seen higher or lower numbers quoted. But that's why I said it is a rare cancer. However, when a woman has a mutation in the BRCA1 gene, you see that risk is between 25 and 60%. And with BRCA2, that risk is about 15 to 25%. This has important implications. I know you guys have already had a talk about PARP inhibitors, I think. And so PARP inhibitors is a treatment decision that an oncologist can use if someone has a mutation in the BRCA1 and 2 genes. But there are also recommendations for management for individuals who haven't developed a cancer. So we do talk about prophylactic surgery, so removing the ovaries and fallopian tubes to prevent ovarian cancer, especially in relatives of individuals with the BRCA1 and 2 mutation if they also test positive. And then the other aspect is considering other cancer risks. So with BRCA1 and 2, we also see a very high risk for breast cancer. Breast cancer is a more common cancer type, about 10 to 13% in the general population. But when someone has a mutation in BRCA1 and 2, that risk can be between 45 and 85%. The 85% is from older studies, so I do think that that's a little bit of a high estimate, but I do like to give people the range. What's important about this is, again, following that hereditary cancer risks, we do see that these cancers often happen younger. And so we do start screening at younger ages. So we'll start screening for a female at 25 if she has a BRCA1 or 2 mutation, and we screen them more carefully. So MRIs from 25 to 30, and then from 30 on, mammograms and MRIs every year. Some women do choose to do a prophylactic mastectomy, so removing the breast tissue to prevent cancer. That's a really personal decision, and I think that's something else I want to highlight is there's a lot of information with genetic testing, but when it comes to you, it's personalized. And so having that conversation with a genetic counselor and your providers to how to use this genetic information to make the right decision for yourself and your family. I don't want to forget about the men, because even though this is a gynecologic cancer talk, we do know that these genes impact men as well. And so men have an increased risk for prostate cancer and male breast cancers with these genes, as well as for pancreatic cancer in men and women. And I see there's a question in the chat. Range. Okay, so the range for BRCA1 mutation of 25 to 60% is so large. Can you explain why it's so large? Similarly with the BRCA2. And so that's a really good question. There's two thoughts. One is the reason why we quote a large range is because we try to incorporate a few different points in the literature. But the second is that we don't know the answer to all these questions, where sometimes we look at a family and there's a BRCA1 mutation and there's not really a family history of cancer. And so suddenly it's a surprise. And then in other families, we see a really strong history of breast cancer or a really strong history of ovarian cancer. And so clearly there is something different between these two families. And the thought is either there might be something in the environment, or now there's more research being done on what are other genetic factors that might be what we call modifiers, so affecting someone's risk. So is it possible that there are some genetic factors that are protecting? Is it possible that there are some genetic factors that are less protective and therefore someone has a higher risk? And so at this point in time, we can't really modify risk. So when I meet with someone, I give them this range because we can't test for other factors that might modify the risk. Though when we do see, younger cancers in a family, we might talk about changing the ages of when we start screening or start recommending surgery. If someone with the BRCA1 mutation has a recurrence while on PARP inhibitors, does that mean the ovarian cancer is not driven by the mutation, but by something like talcum powder? So cancer is a very complicated process. And so sometimes we see that cancers, I'm trying to think of the right word. Something might have caused the cancer to begin with, but then over time, the cancer kind of adapts. And so that's sometimes why someone will stop responding to different types of therapies. but I do direct you to your oncologist to talk about the specifics of the cancer, because it also depends on the cancer types. But oftentimes we do see that sometimes someone might have a BRCA1 or 2 mutation. They actually might test the tumor, and later we don't see the mutation anymore. And that's because the cancer itself has mutated to adapt. That is a whole nother conversation, a whole more detailed, but what if you have no genetic mutations and the tumor was completely negative? So I just want to actually address that, because I think that's a really important piece. When someone has genetic testing, there's two types of genetic testing we could be referring to. One is referring to testing the tumor itself, and that's part of helping with treatment management. And so when someone's cancer has a mutation, we don't know, is that something someone was born with or something that happened over time? Sometimes there are mutations in a tumor that we wouldn't expect to see someone born with. And so it's just confined to the cancer, but also there are different technologies and interpretation done on tumor testing. And so just because someone's tumor is negative doesn't mean that they don't have any mutations that they were born with. So I think that's a really important note, that even if tumor testing is negative, if you're in discussion with your doctor, you think that genetic testing might be right for you, I might still recommend it. The other thing is that we don't know everything about genetics right now. And so one, most cancer does happen by chance. Two, it's possible that there might be a genetic cause in a family that we just can't pick up right now. And so sometimes that's part of what I discuss with patients as part of the post-test, is looking at a family, what is the chance that this just happened by chance? Is there another suspicion in the family because of a family history that makes me more suspicious that we might be missing something? Or maybe something that technology just can't pick up right now. And sometimes we do see people tested negative in the past and then test positive. And then I'm going to answer one more question now and then continue. Can you tell us other cancers that are related to BRCA1 and 2? Yes. So some of the other cancers related to BRCA1 and 2 include, like I mentioned, prostate cancer, breast cancer, and pancreatic cancers. There are some studies regarding other types of cancer. So right now we think that melanomas might also be linked to BRCA2. There are specific types of uterine cancers that are linked to BRCA1. And so it could be that someone has a uterine cancer, and based on the pathology, their oncologist is recommending, or a gynec is recommending, that they have genetic testing because of the specific pathology. So these are all factors that we could discuss. Okay. I do also want to talk about another condition called Lynch syndrome. That's named after a doctor who discovered it, Dr. Lynch. This is related to a few different genes, and I only chose two to give as examples because one is the higher end of risk and one is the lower end of risk. But these genes are linked to endometrial cancer and ovarian cancer. So with MLH1 associated Lynch syndrome, MLH1 being the specific gene, if we are quoting about a 3.1% risk in the general population to develop uterine cancer, the risk to develop uterine cancer by the age of 80 is between 34 and 54%. And for ovarian cancer, about 4 to 20%. But if you look on the other side of the screen at PMS2, you'll notice that those risks are lower, as well as that the ages of diagnosis are later. So we would say MLH1 carries a higher risk for cancer, and we see younger ages of onset compared to PMS2. And sometimes we then can see different patterns in a family. So for someone who has MLH1 related Lynch syndrome, we might see more cancers in the family and younger ages of diagnosis, whereas with PMS2, we might see more scattered cancers. And to answer also that question of what are some other types of cancers, we do see with these genes some GI related cancer. So colon cancer is at a higher risk with these genes, as well as gastric, small bowel, pancreatic, But as you see here, also renal, pelvis, and ureter cancers, bladder cancers, and brain cancers to differing risks. So this could have implications not only for females in a family, but men and women because of the other non-gynecologic cancer related risks. And so I think ovarian cancer, we talk a lot about the genetics of it, but endometrial cancer is also important. There's a couple considerations when having testing. So number one is that when we do a genetic test, and this is related to the person who asked that question about if I have a BRCA1 mutation, is that the cause of my cancer? Sometimes based on the genetic result, we can more easily say, based on this result, this is why this individual developed cancer. And so having an answer is sometimes a reason enough why someone might think about genetic testing. They're searching for answers, but then I caution sometimes we don't find an answer. The second is related to PARP inhibitors and some other treatments that are specifically gene related and pathway related. So this can help oncologists guide treatment decisions. And then also understanding the risk and management recommendations for other types of cancer. So someone might know about the gynecologic cancer in the family, but might not have thought about colon cancer risk or wouldn't have had a colonoscopy. And then the last is for family members. And we've talked a lot about what does someone who tests positive do? But if we find an answer to someone and then their family member tested negative, then we can say, this is what caused the cancer in the family. If you don't have it, oftentimes you don't have to worry about it. And then that person might be managed differently, even though they have a family history of cancer because they tested negative. I'm going to look at the questions. Can one have a BRCA mutation, but not be the cause of the cancer? Yes. And I'll talk about that more when I talk about moderate risk genes, which is the next topic. But cancer, we all are at risk to develop cancer just by being human. And so sometimes finding a mutation does not mean that was the cause. It really depends on the type of cancer, certain features of the cancers. And we see that more actually with what we call moderate penetrance genes. So BRCA1 and 2 and the Lynch syndrome genes, I kept referring to as higher risk genes, but some of those other genes that you actually saw on that previous slide that you might not have heard of before, some of them are what we call moderate risk genes, meaning the risk for cancer is lower. And so the chance that someone with a mutation develops cancer is lower. The management recommendations we might make for individuals might be different than what we recommend for someone with Lynch syndrome or BRCA1 and 2 mutation. And the thought about how that happens is often related to people use the jar image. And so if you think about someone developing cancer as the jar overflowing, so genetic factors are these little yellow balls. So they fill up the jar some ways, and some genetic factors might actually empty the jar and be protective, but it doesn't cause the jar to overflow. But over time, environmental factors or factors that we can't account for right now fill up the jar, and that can cause someone over time to develop cancer. So it's really both genetic and the environment and factors that we don't know about yet that can impact someone developing cancer. So if we think about BRCA1 and 2, that fills the jar really high up. So that person's risk for cancer is pretty high because they're already almost full. Whereas some of these moderate penetrance genes are only filling up the jar a little bit. So that might not be the full reason why someone developed cancer, but a contributor to developing cancer. Just to give you a sense, if we compare these different genes to the population, BRIP1, RAD51C, RAD51D, these are all genes that are more moderate risk. And so as you see, compared especially to BRCA1, that risk is very different. And that comes back to what was asked before about it being the cause. When we find a moderate penetrance gene, it's really important to look at the family history, the person in front of us, and to ask the question, is this the full story? So if someone has a genetic change in one of these moderate penetrance genes, but they have a very strong family history of cancer, I'm not convinced that that would be the full story as to why someone developed cancer. And that also has implications for relatives, because if this genetic change isn't the full story to the cancer in the family, then maybe even if someone tests negative, they might need to be watched more carefully. Or maybe relatives need to have additional testing. And so interpreting results is also important in the context of everyone's individual history and family history. Some other considerations when it comes to genetic testing is incidental findings. And so we can test for multiple genes at different times, but sometimes we find out results that we weren't expecting. So, someone has a family history of X and suddenly we find out that they're at a high risk for Y. So let's say Lynch syndrome, there's a family history of uterine cancer, and suddenly I start talking about colon cancer risk and colonoscopies. That could be very jarring for someone. However, on the other hand, by finding out the other types, we can manage people differently. When we do genetic testing, because genetic testing technology has advanced, we're able to test for many genes at the same time and often at no additional cost. So it used to be that genetic testing cost $2,000. Now, most insurances cover genetic testing, and if genetic testing is not covered by insurance, it's about $250 out of pocket, which I know if someone had genetic testing a few years back, that was not what we were talking about. And a lot of labs also offer financial aid for someone who cannot afford the $250, but insurance won't cover it. So cost of testing. I'm sorry?
Woman to woman will also help with that to cover genetic testing for women.
Yeah, so we can definitely, the cost of the test should not be the barrier to someone receiving testing. But while we're doing testing, the question is someone interested in learning about other types of cancers? So those pictures I showed you about genes, those are what we call panels. So that's a group of genes. That's the breast and gynecologic cancer panel. But I can also add on colon cancer genes, or I can also add on prostate cancer genes, or I can also add on pancreatic cancer genes, often at no additional cost. But sometimes people don't want that type of information. And so when deciding about genetic testing, it's also important to decide, what is the purpose of this test? And, what type of information do you actually want to learn? And that's something that, as part of genetic counseling, that we really have a detailed conversation about. The other factor we think about is what type of information can I learn in the sense of some genes like BRCA1 and 2. I have that really nice chart I showed you. I have very specific medical guidelines to talk to someone if we find something. But then we have this other category of what we call preliminary evidence genes. Those are genes that we're still learning about. So science says that we think it's linked to ovarian cancer, uterine cancer, insert cancer here, but what is the actual risk? We're not fully sure yet. What do you do about it? There's not enough literature to make medical guideline recommendations, or the risk is low enough that we say someone doesn't need extra surveillance or management. So sometimes I have patients who say, if this isn't actionable, I really don't want to know about it. Whereas others say, that at least will give me a direction to follow over time, and whether it's relevant or not over time, we'll just have to see. And then the last thing that is an important factor is what we call GINA, or the Genetic Information Non-Discrimination Act. That's a law that says that health insurance cannot use genetic information to discriminate against someone. So, for example, health insurance cannot say, this person is at a higher risk for cancer, I'm going to deny coverage or raise premiums. However, that law does not cover life insurance, long-term care, or disability insurances. So sometimes someone might want to think about getting all of those insurances in place before thinking about genetic testing. So that's also a factor to consider, especially when we think about relatives. Someone who's in their 20s often doesn't have life insurance, and so it's a completely new conversation. I'm just checking in on the questions. The other thing I keep mentioning is changes to technology. So this is from one of the genetic testing labs that we send testing to, a timeline of genetic testing advances. So in 2006, we added what's called deletion duplication analysis. So if you think about genetic testing as spell check, so reading letter for spelling changes, until 2006, especially in BRCA1 and 2, we can do what's called sequencing, that's spell check letter by letter. But spell check misses if you have a whole paragraph deleted. And we now know that many mutations in BRCA1 and 2 are actually what we call rearrangements, so pieces of the gene extra, missing, or in the wrong place. And it wasn't until about 2006 that we could start detecting those. In 2010, we had the next advancement, which is next generation sequencing, which allows for, first of all, the cost of testing to go down, but also the ability to test for multiple genes at the same time. And so that's why that panel testing became available. So testing for multiple genes at the same time. So it used to be really burdensome. We had to test one gene at a time, start with these two genes. If that person tested negative, then think about adding additional genes. But now we can really do most of it all at once. And then in the past, I was going to say last year, but it's 2021 already. So in 2019 to 2020, this lab launched what's called RNA Insight, and a few other labs have since launched that. That's another technology where what they do is they look at the gene product, which is called RNA, which many people have heard about because of the vaccines, but they read through the gene, but then they also look at the gene product. And if the gene product is abnormal, that allows them to reassess what they did with the gene testing. And so sometimes we're able to pick up mutations that weren't previously picked up. It hasn't been published information, so I don't know yet how reliable it is, but I have seen numbers of up to 3% chance of detecting a mutation that wasn't previously detected using RNA analysis. So if someone has a really strong history and they feel like they haven't gotten the answer, if the testing was done before 2019, we can consider doing additional testing. Not all insurances will cover the RNA Insight, but as we discussed, there are a lot of different options regarding the cost.
Tehilla, would you mind just slowing down a little bit?
Of course, I drank a lot of coffee today, so I apologize if I'm talking too quickly.
I'm a fast talker, but you're competition for me. So if you could
okay.
This is so important what you're saying. Thank you.
Let me just restate what I just said. We can now test for more genes at the same time that wasn't available before about 2012, 2013. We can also use a newer technology that the pickup is not extremely high, up to maybe 3%. But if someone has had negative genetic testing in the past and you are still interested in potentially looking for an answer, or it's been in the back of your head, we're happy to meet with you and look through what you had already, see if all the genes that we would think about were looked at, look at the family history, and try to determine, is it worthwhile to update testing? And as we had said before, cost should not be the barrier to that decision making, that we would work together about that. Okay. The last thing I want to talk about is possible results, because I think this is something that comes up a lot and is specific to genetic testing and causes a lot of anxiety. So with genetic testing, we have three possible results: a positive, a negative, and then that question mark result. And I'm going to explain a little bit more about what these results mean. So if they're reading through the gene and they're expecting to see something like CAT, a negative result is when they see CAT. So they've read through the gene, they don't find any changes that they think is affecting the gene's function. So that's negative. Again, based on the questions asked, we had talked about just because someone has negative genetic testing does not mean that there's not something hereditary in a family, but we couldn't find anything. The second result is positive. So if they are expecting to see CAT and they find XAT, they know that instruction does not make any sense. It no longer says CAT. It doesn't work. And that person is at a higher risk to develop cancer because they are less protected. And then we have what to talk about risks, whether that explains or does not explain a personal or family history. What does that mean for relatives? But then the third result is where I think people get really anxious, is this variant of uncertain significance or unknown significance, depending on what lab you send your testing to. And that's when they find something like KAT. So it still says CAT, but it's spelled a little different. And so the lab isn't sure, does this impact the gene function and cause the instruction to get lost? Or is this really just what makes one person different from the other? We all have a lot of genetic variation. Most of it does not affect our health. And so is this really just normal genetic variation? And the laboratories that do genetic testing are under very strict guidelines about how much information they need to call something positive, but also how much information they need to call something negative. So when they don't have enough data for positive or negative, they just leave it in this limbo stage called a variant of uncertain significance. A recent study showed that more than 90% of the time, these variants end up being downgraded, meaning they ended up being negative. And so we treat these as innocent until proven guilty. So if someone has a variant of uncertain significance, the party line is keep calm, it's innocent until proven guilty. However, I do put an asterisk there. We will always do research on the side to see if there's any other reason to call it a different way. But in general, we do not make clinical management decisions based on these variants. They're extremely common. The more genes we look at, the more likely we'll find them. And I just know that, getting a question mark on any report, especially when someone is trying to make decisions about their own health and their family, is really anxiety producing. And so I just want to put it out there that these variants are mostly nothing. And sometimes I think my record is like 6 variants on one test. So they're very, very common. Okay. I'm going to talk about the last part while also putting up this information. This is our team. We're always happy to talk to you or family members. So part of genetic counseling is that we can help coordinate care for, test one person and then think about who else in the family might need testing. We're happy to talk to family members. So a lot of this information is very complicated and also very emotional. And so sharing that with families, we're always happy to help with that discussion. Or I have a lot of patients who give their family members my phone number and say, just talk to her. She'll talk you through it. We can help coordinate testing for family members. A lot of labs do have family member testing options. So if we do find a mutation in someone, the lab often will do free testing for family members within a certain amount of time. So that cost, again, should not be a burden or not the reason for someone not to have testing. There is also, and I should have put this up, but I'm going to tell you about it and maybe put it in the chat. There is the National Society of Genetic Counselors has a support that's called Find a Genetic Counselor, which allows family members to just put in their zip code and the type of genetic counseling they want. So in this case, cancer genetic counseling, and they can find a genetic counselor nearest them. So for example, my team can only counsel people who are physically in the state of New York and New Jersey at the time of appointment, but a lot of families are spread out across the country, across the world. And so that resource is available. We are also always happy to try to help find genetic counselors in different areas to help coordinate testing for family members. And so part of genetics is that it's a family conversation. And so we are always happy to help meet with families. Sometimes families like to come together. We're happy to do family sessions. Sometimes families like to come separately. We're also happy to help with that. That is all I had. So I'm happy to answer any other questions. And I do apologize if I spoke too quickly. So if there's anything that you want me to go back to, I'm also happy to do that.
I think that was really great. Thank you so much.